Thank you, everybody, for joining us, which is evening for you and morning for our speaker. My name is Joseph Zohar, and I am the president of CINP. And this is my great pleasure to have Geraldine Dawson to participate and to give a talk in our educational activity, which is part of a series of webinars that we are doing. And this is actually in part of the mission of CINP, the College International of Neuropsychopharmacology, which is to increase awareness and knowledge and improve the treatment and diagnosis of disorder of the brain. Geraldine Dawson is a distinguished professor of psychiatry and behavioral science at Duke University, where she is also the professor of pediatrics and professor of psychology and neuroscience. And basically, she works on autism, and she works on interdisciplinary approach to autism. Her center is also part of NIH Center of Excellence, and she has been doing really innovative and extremely important work on digital health approach to early detection of autism. So Geraldine, the floor is yours. Thank you.
Well, thank you very much. And I appreciate having this opportunity to talk about the work that we're doing. And I also appreciate that some of you are staying up quite late to see this talk. And so, you know, I feel honored that you're doing so. I'm going to start with the take-home message. And the point I want to make is that we need a multimodal approach to thinking about screening for autism, but also for other psychiatric conditions. And so I ask you to imagine that you were worried that you had a heart condition. And so you went to the doctor, and the first thing the doctor would do would be to ask you about your symptoms. You know, are you feeling out of breath? Have you had any chest pain, and so forth? And so your self-report is a very key part of what the physician would consider in making a referral for, you know, assessment. But then the physician would use other information. For one thing, the physician would actually monitor your heart using the EKG, so have objective quantitative assessments of the organ that's in question in this case. And then also other factors such as your cholesterol, your blood pressure, whether you have, what is your exercise, what is your family history. And all of that information would be integrated to make an informed decision about your care. And what I see in psychiatry, and particularly screening for autism, is that we're relying really solely on the parent report and not incorporating other objective measures. Now, I'm going to be talking about two other sources of information. I'm going to be talking about digital phenotyping and also how we can use information in the electronic health record. But you could also consider EEG biomarkers. People, including here at Duke, we're doing a lot of work to come up with other objective means for early detection or stratification of autism. So why do we need this new approach? currently, the American Academy of Pediatrics recommends that all children be screened at 18 and 24 months with a parent questionnaire. And usually this is the modified checklist for autism in toddlers. Now, when we use this in research settings, the accuracy is quite good. But when it's used out in the real world, such as in primary care settings, which is where the screening occurs, the MCHAT's accuracy is really not very good. So, for example, a large study that was published by Guthrie et al. In 2019 in a large pediatric network, they found that the sensitivity was 39%, the positive predictive value was 14.6%. And this is partly because the providers are not using the follow-up interview that is required to have a more accurate score, but there are other factors coming into play as well. And we also know that the accuracy of parent report is lower for girls and for Black and Latino children and for children whose parents have lower education levels. So we know when you rely solely on parent report measures, there are literacy issues that come into play, language barriers. It does require that the parent have knowledge of child development. And there are well-known cultural differences in how these questions are interpreted. So our goal was to come up with an approach that would reduce these disparities in access to care by providing scalable, objective measures that are based on direct observation of the child's behavior. And keep in mind that autism and most psychiatric diagnoses are behavioral diagnoses. So what we wanted to do was to have an objective way of actually quantifying the differences that we see in behavior that then would signal that the child likely has a diagnosis of autism. So how are we doing this? We developed an autism screening app called Sense to Know. And this app can be shown on an iPad or an iPhone. And it's a set of strategically designed brief movies and also a game that are shown to a toddler while the toddler is sitting on the parent's lap. Now, while the child watches these movies, the camera in the device is recording the child's responses. And then these are automatically quantified using computer vision analysis. And I should point out here that the work on computer vision analysis and machine learning and computer science has been led by Guillermo Shapiro, who is also a distinguished professor here at Duke, and he has a large team of postdocs and students who have worked on this. Actually, we've worked on this over the past 10 years together. So then from this quantification through computer vision analysis, multiple behavioral features are then combined using machine learning to provide an objective screening algorithm. So let me give you an example. Here's one of the movies, or part of it. So one of the things you'll notice is that the objects are located on one side of the screen and the person is located on the other. You can see the device's camera can record the child's behavior. And we're noticing what is the child responding to and paying attention to when they see this movie. So for example, are they paying mostly attention to the objects or the person? And a neurotypical toddler actually would be, their gaze would be alternating back and forth because they would find both of these interesting. But in addition to gaze, as you'll see, there's many other features that we can record while the child watches these movies. And I'm going to show you some examples. So using this approach, we've been able to demonstrate that we can measure using only the device. So no special eye tracking equipment or any other equipment is needed. In fact, our studies now involve the parent doing this at home by themselves. Now, we aren't providing the screening information direct to the parent, but the actual administration can be done in the home, and then the videos are sent to the provider, and the readout in terms of the screening information is provided to the provider, then to get back to the parent. But these are the range of behaviors that we can measure: social attention, attention to speech sounds, whether the child is responding to their name being called, their facial expressions and dynamics, head movements, blink rate. And then we have a bubble popping game where we're measuring the accuracy of the motor skills, because we do know that delays and differences in motor development are one of the very early features that we see in autism. So let me give you a few examples. So first, we were very interested in demonstrating that we could monitor gaze using solely an iPhone or an iPad, no eye tracking equipment, and sufficiently be able to distinguish between a toddler with a diagnosis of autism versus not. Here's another example of a movie. You can see the same kind of idea with a person on one side and people on the other. We've known for years that individuals with autism actually throughout the lifespan have very different patterns of attention, where they do tend to pay more attention to objects than people when they see a scene like this. So we're really capitalizing on well-established research, but taking it into the realm of being able to do it solely with an iPhone or an iPad without any other kind of equipment. So here's a paper we published in 2021 in JAMA Pediatrics, and you can see the distribution of the gaze patterns, where when the person is on the right, you can see the neurotypical toddlers are shifting their gaze mostly to the right, whereas you can see the autistic toddlers are shifting to the left. And then when we reverse the sides, you can see that the pattern of attention is different now, where the neurotypical children are paying more to the left side. And this was a study of 367 neurotypical children and 35 children on the spectrum. Here's another example. So in this example that was based on research that had been published with 10-month-old infants, we had two people engaged in a conversation. And what we had known from the literature is that by 9 to 10 months of age, a baby will track visually the conversation of two people, even though they don't understand the words. And you can see here at the top that this is an example of an autistic toddler, that their gaze pattern is much less coordinated than a neurotypical child who's able to quickly go back and forth as the conversation goes from one person to another. Now, one of the really interesting things about using this approach is you can discover new biomarkers. Here, what we're doing is looking at head movement, and I'm plotting at the bottom the cumulative frequency of head movements while the child is watching the movie. And you can see that the autistic toddler shows much more frequent head movements. Now, head movements are not part of our screening tools currently in autism, and yet this is one of the most robust biomarkers that distinguished between autistic and neurotypical toddlers, is simply the amount of movement of their head while they're watching the movies. Here's another example. In this case, what we're looking at is the complexity of the facial expressions using multi-scale entropy. And what we found was that the autistic toddlers exhibit higher complexity in their landmark dynamics. And this reflects a higher degree of ambiguity or unpredictability in their facial expressions. Now, this is another interesting measure where it would be impossible for a clinician to be able to detect this. But it turns out that when we're interested in something, we suppress our blink rate. And this is not only autistic children, but also you and I. So this is a universal sort of unconscious phenomenon where when we find something interesting, we want to enhance the intake of that visual information. So we tend to suppress our blink rate. So we can readily measure blink rate, and what we found was neurotypical toddlers suppress their blink rate, meaning they find it more interesting when they're shown a social stimulus. So this is one of the movies where a woman is singing a nursery rhyme, as compared to dynamic toys. Whereas autistic children did not suppress there was no difference between the social and non-social stimuli. Now, recently, we pulled together all of this work where we had individually validated these digital phenotypes into a study that combined them into one algorithm. So in this case, the app was administered during a well child visit in primary care clinics to 17 to 36-month-old toddlers. And I should point out that all of the studies that I've shown you so far have all been conducted in a primary care clinic. So from the beginning, we did not develop this in the lab, but we really developed it in collaboration with pediatricians working in the clinic to determine how this could be administered during a well child visit. And that's really important because it is one of the most challenging things is to administer this kind of tool in the wild, so to speak. And now we're about to publish a study where all of the administrations were done at home. And I think that's really important when you do this work because there's such a difference between a lab environment where everything is controlled in terms of lighting and so forth versus, different clinics and home settings. But in this case, it was done in Duke primary care clinics. We had 475 toddlers who came in for their well child visit. They were screened using the MChat. And then subsequently, children were referred if there was concern. And 49 of those children were subsequently diagnosed with autism spectrum disorder, 98 of them with developmental or language delay without autism, and the rest were neurotypical children. Now, we have designed the app so that it also automatically assesses the quality of the app administration. So there's a quick screening that tells you whether or not enough data was received to make a valid prediction. So was the child looking at the video, sitting in the lap? Was the child's face in the screen and so forth? So that can be done automatically because eventually what we want to be able to do is to provide that feedback so that if there was a poor administration, you could tell the parent or the provider that they needed to re-administer it and that the administration was not of sufficient quality to make a good prediction. So in this case, we found that the sensitivity was 87.9%, specificity was 80.8%. And there was no difference in the sensitivity and positive predictive value for children of different sex, race, or ethnicity. The only difference was the negative predictive value for the Black children was not quite as good as the other subgroups. But other than that, there was no difference across these different subgroups. Now, the other thing is that the app generates a unique behavioral profile for each child. And so you see here two examples. So this is a neurotypical boy, 25 months old. And using what's called SHAP analysis, the app tells us what were the features that contributed most to the prediction. So what did we see that made us believe, or what did the computer see that in terms of the algorithm that said that this child was neurotypical. So you can see the most important feature was facing forward during the social movies. But also the second one was that social attention variable. Third was response to name. Fourth was the accuracy during the bubble popping game. Fifth was their eyebrow complexity during the non-social movements and so forth. The autistic child, very similar sort of in terms of the ranking of these features was similar, but they were going in the opposite direction. So in this case, there was low facing forward during the social movies. Oh, one more thing before I leave this, which is that the prediction is also accompanied by a rating of the confidence level. So you can imagine that there are children where the majority of these phenotypes are indicating autism, whereas there's going to be other children where it's a little more ambiguous and similar for a neurotypical child. So there's a confidence rating that would say, for example, that the chances that this child will have a diagnosis of autism is certain number of percent. Now, before I end, I also wanted to tell you about another line of work that we're doing here at Duke, which I think is really important, and it gets back to this concept of multimodal assessment. So the accuracy of autism screening can also be improved by incorporating information from the electronic health record that is just collected as part of routine healthcare. So again, these studies have been done in the context of Duke and the Duke Health Network. And so for most children, we have extensive information about their medical history that we can incorporate into our prediction modeling. And this work was motivated by a paper. This was led by Matt Engelhardt from the Department of Bioinformatics and Biostatistics here at Duke. And the first thing that his team did was to examine the patterns of healthcare utilization in babies at age 1 who later were diagnosed as either having no neurodevelopmental condition, having autism, ADHD, or an upper respiratory infection. And you can see the autistic kids are the kids in orange, and the ADHD children are in green. And you can see, first of all, a very different pattern of healthcare utilization for a 1-year-old who's going to go on to have a diagnosis of autism versus ADHD, and also very different than a neurotypical child. So we can see, for example, that autistic children are much more likely before age 1 to be visiting an ophthalmologist, to be having physical therapy, to be seeing neurology, gastroenterology, and endocrinology. Now, interestingly, the GI issues that required a referral to gastroenterology were showing up by 3 months of age. So what we see is that, and this really speaks to the idea that autism is more than a behavioral health condition. It also is accompanied by many physical health conditions. And these clearly are showing up very early in life. This was a sample of almost 30,000 patients, of whom 343 were autistic, and over 1,000 ended up with a diagnosis of ADHD. Now, the kids with ADHD had a very different pattern. For example, they were much more likely to have visited an emergency department room by age 1, which is, of course, very fitting in terms of thinking about the early pattern of ADHD and risk-taking. We recently published a paper. This again was headed up by Matt Engelhardt and his team, where they looked to see whether you could then use machine learning using all available information from the electronic health record. So this is everything from labs to procedures to diagnoses to specialty visits and so forth. And combining that, can we begin to predict by age 1 in this case that the child will go on to have a diagnosis of autism? And you can see even by 30 days, we have a specificity of 45.5% and a 90%. I mean, sorry, that should say be sensitivity instead of specificity. 45.5% sensitivity, 90% specificity. And then by 1 year, you can see the sensitivity increases, and we have about 80% specificity. We also recently published a study where this is Ricardo Henio's work and his team, but we used natural language processing to derive information from the clinician's notes and showed that combining that with these more structured electronic healthcare data then increased the prediction beyond the numbers that you're seeing here. So our future vision is this multimodal approach to autism screening. And so you can imagine that by, say, 18 months of age, that we would already have a lot of information from the EHR. This would be collected automatically, it would be passive, it would be objective, so that when the pediatrician comes into the office, they're already getting a flag if this child looks like that they have a high likelihood of a neurodevelopmental condition. Then you would also still do the screening with parent report. We think this is very important. And then also follow up with a digital phenotyping approach, which would be a direct observation of behavior that doesn't require language and have the biases that are built into parent report. And these would be combined on a dashboard. So this is what we call clinical decision support. So this is a very robust area in all of medicine, which is the idea that physicians are provided automatically with information in their electronic health record that is also combined with advice about what their actions should be. So actionable advice. So this is important because it turns out that even when a child has a positive MChat, about 60% of physicians don't make a referral. So even if we have great screening tools, unless the physicians are then appropriately referring the child for a diagnosis and intervention, this isn't going to help us. We conducted a small study where we simply provided screening from the MChat with information about what the physician should do. And this came automatically, and it included all of the referral services and a handout that could be automatically sent to the parent. And we were able to increase the rate of referral from about 40% to 85%, and also increase accuracy of documentation in the electronic health records. So we have another team at Duke that is working on designing these clinical decision support tools, which would provide all of this information to the physician, as well as provide advice about next steps for the child and family. So I'll just end there. I want to thank all of the funding agencies and, of course, all of the families and children who have participated in our studies. And I always love this painting, which is by an autistic artist of one of our buildings here at Duke that is that we all love, and that is Duke University Chapel. So I'll stop sharing so that you can ask questions, and I'm happy to open up the PowerPoint again if we want to look at any of the data that I showed, but I know that you wanted to have some time for questions.
Yes, thank you very much. Highly appreciated, very clear and innovative. Is there any question from the audience? Yeah, Yusuf.
Yes, thank you so much. Big question is, what do you do once you have diagnosed? How effective can we intervene, really? That's really the most compelling question I have.
Yeah, that's a very good question, because we don't want to screen for something if we don't have a way to help. There is a very robust literature on the efficacy of early behavioral interventions in autism. So this work, as you may know, and this is just a part of a very large literature on early intervention, but I'll focus on our own work. So we developed a model called the Early Start Denver model, and this is what's called a naturalistic developmental behavioral intervention. This is a field, these NDBIs, that now are comprised of multiple models that have been validated now. And our model, which is called the Early Start Denver model, is just one of these. But these NDBIs, or naturalistic developmental behavioral interventions, are based on applied behavior analysis, but they take a much more naturalistic approach. So following the child's lead, being sensitive to the child's natural preferences, using naturally occurring reinforcers rather than artificial reinforcers. And it's a very play-based approach, but still based on the science of applied behavior analysis. And these have been tested in multiple NIH-funded randomized clinical trials. So we published a paper in 2010, which was a randomized clinical trial where children were either received the ESDM treatment, Early Start Denver model. This was 15 hours a week, so this was an intensive treatment, and they received it for 2 years, versus they received just the standard of care in the community, which did not involve this intensive approach. The average IQ gain was 17 points, but we showed robust impact on language and cognitive functioning. We also followed these children longitudinally and showed that the IQ and language gains were sustained up to age 6, and that they required subsequently much less in the way of intervention. In fact, we published an economic analysis where we showed that after the intervention was done, that there's a savings of about $19,000 a year for children who had received the intervention. Now, since that study was done, there have been published a multi-site NIH-funded randomized clinical trial of the Early Start Denver model, which replicated the findings in terms of the improvement in communication. That was our strongest outcome, but there were significant improvements in communication. There was also a recently published study where children were randomized to receive either a naturalistic developmental behavioral intervention versus much more traditional applied behavior analysis to see whether one was more effective than the other. And in this study, there was also a randomization to either receive 15 hours versus 25 hours a week, again, for over a year. And interestingly, we did not find differences between traditional ABA versus a more naturalistic approach, or even differences between 15 and 25 hours. The children in both groups who received 15 hours did substantially better, but the actual mode of intervention did not make a difference. So that's just a sliver of the work in this area. There have been meta-analyses, for example, of the Early Start Denver model. It's been translated into 17 languages. There's been 45 studies that have been outside the US of that model. So I do feel like there's, and in fact, in the United States, insurance companies now pay for early intensive behavioral intervention because of the strong efficacy data. So we do have things we can do, and there have been studies in Japan and China that have looked at the Early Start Denver model. But yeah, so I do feel like we have things to offer families. And in fact, one of the areas that's a very active area of research now is developing infant interventions. And we've done some of this work, but there's other groups as well that have been looking at how we can teach parents to use strategies at home that will facilitate early language and social development beginning at 6 to 12 months of age. And we've published some of those studies. We've even used electrophysiology as an outcome and shown that we can improve some of these EEG biomarkers based on infant interventions. And we also have another study with preschool showing impact on electrophysiology and changes in brain activity as a result of these interventions. So, I mean, I could go on and on because it's my other area of research, but yeah, I do. I know one thing I will mention is that there is a very robust area of research on how do you address regions that have low resources, because obviously there's many places where you're not going to be able to deliver these intensive services. And the approach that's being there, so I'll tell you about the work that's being done by my colleague here at Duke, and she's working in Africa. So in that country, she also is using a parent-delivered version of the Early Start Denver model. But first of all, community workers rather than specialists have been trained to work with parents to teach them these strategies that they can use at home to promote language and social development with their own children. And she's already published studies showing that parent delivery of these interventions can be very useful and are associated with improvements in language and social skills. So she's now conducting a NIH-funded randomized clinical trial in South Africa and Tanzania, where, again, these community workers who are non-specialists are training parents to deliver interventions and showing really good success. So I do think there are some interesting approaches that are being used in communities that don't have specialists available and can't provide intensive services.
Thank you very much. Best of luck.
Yeah. Thank you very much. I would like to, to take it to other direction. What do you think, how it could be, how we can use it in other disorder? Because basically we are trying to do this kind of triage or screening, let's say, for PTSD, which is, and I guess the same principle should apply. What is your take about this?
Yeah, absolutely. I think the work we're doing is, we're applying it to autism, but most psychiatric conditions are behavioral conditions, right? That's how we diagnose them. And certainly there's a lot of work being done in other areas. For example, rate of typing for a person with depression. So there's a lot of digital approaches in trying to pick up on changes in behavior that would indicate that someone has a particular condition. We have applied our specific approach using this app with children up to age 10. We have studies now that are in press with kids up to age 10 that look at autism versus ADHD. And we do find a different digital signature, so to speak, for children who have ADHD versus autism. So that's an example of, where you would, and I also know there's work being done here at Duke by Guillermo Sapiro and his team on eating disorders. So in this case, for example, they're having kids who are being served food and looking at their disgust or other kinds of reactions on their face and how that changes with intervention. So I do feel like it's an approach that could be used with many different conditions. Anything I think that involves eye tracking. So if where you pay your attention is an important digital signature, so to speak, then this kind of approach I think could work well. In terms of electronic health records, that's being used with a wide range of medical conditions. Everything from trying to predict whether this person would respond to one medication versus another. There's published studies on using the electronic health record to predict suicide risk, to predict whether a person is likely to come back to the hospital after they've been released from the hospital. It's a really active area of research in the medical community, including psychiatry. So autism is just one example of that, where we're starting, early in life.
Yeah. Great, thanks. Any more question? I don't see any ends. Kazoo, you'd like to? I see. Yeah. Yeah. Just before we move to Kazoo, what is your question, Yamasuto?
Yeah.
Yeah.
Thank you the opportunity. Thank you very much for your excellent talk. I was very much inspired by your recent Nature Medicine paper. So this is a great opportunity. And I have one practical question. How do you think about the possibility that FDA can approve your application based on your recent findings, or much further findings is needed? How do you think about
Yeah, that's a good question. So currently we are conducting what would be considered a pivotal validation study with the goal of FDA clearance. So we are working closely with the FDA, who in the design of this study, it's fully launched. We've screened about 180 children and fully tested about 80 children. It'll take a couple of years. So this is a very rigorous study. It also incorporates what's called repeatability and reproducibility studies, where you're repeating it with the same child or with a different device and so forth, and making sure that it's reproducible. And also what are called human factors study, where you really look at all the potential ways that based on human factors, it might, there might be a problem in the delivery and so forth. So we expect those studies to be completed in a couple of years, and hope at that point to be able to consider, distribution on a wider basis. Yeah. And I did notice there's a question in the chat about distinguishing between autism and ADHD or other autism and early detection. So we do have some studies that we've published one study where we compared autistic children versus ADHD, and I can send you that paper. But it was looking specifically, it was the paper that was looking at the motor, the bubble popping game, and looking at specific aspects of motor skills. And we did find that the children so we had 4 groups in that study: children with autism, children with ADHD alone, children with both autism and ADHD, because remember, about 50% of people with autism also have ADHD. It's highly co-occurring. And then neurotypical children. And we were able to show differences among those groups in how their motor skills and the type of motor sort of delays and accuracy that they had. So that's one paper, but we have another paper coming out that's looking more at attention and also showing the ability to distinguish. Now this app and the movies were really designed around autism. If I were going to focus specifically on ADHD, I might design, I think the motor, the bubble popping game is quite good, but there might be other things that I would design, right? So one way to think about this is that when you're thinking about designing an app for a different condition, you're going to want it's the stimuli that you're going to change. And you're going to use the research literature to design those movies. But I think the technology in terms of using a smartphone or an iPad and all of the computer vision analysis, the machine learning, that I think is something that could apply across the board. It's really the stimuli that one would have to change to be specific to what you're trying to capture for that particular condition.
Thank you very much.
Thank you very much, Geraldine, for this excellent talk. It's certainly the future. We need to recruit our honest technology in order to help us to do better and early diagnosis. Thank you very much.
My
Kazoo?
pleasure.
Yeah, thank you very much for your wonderful talk. So I have one question. So I'm investigating behavior of animal models of autism. So, and you showed 23 digital phenotypes in patients. And I think several of them can be applied to animal models. So have you ever tried such approach?
Yeah, that's a great question. I do know that there really has been for a while now a focus on digital approaches in animal models. So as I'm sure aware, because you do this work, it used to be that we would behaviorally code the animal's behavior, right? Which is just like in autism, it's such a labor-intensive process to teach people to code these different behaviors. And so some of this was actually motivated by the work that we've seen in the animal models. So an example will be using ethovision, right, to track movement, which has been done for quite a long time in animal models. So we've published a couple of studies where that's another area of research that we've been exploring, which is, can you use digital approaches to track movement during parent-child interaction? And can it tell us something meaningful? And that's very similar to the work that they're doing in animal models. But you can imagine, for example, with animal models, ultrasonic vocalizations, whatever the behavior is, the idea is to be able to use a computer to do a better job, honestly, at quantifying those. But the other piece is that almost everything is sort of, there's multiple behaviors, and we can use machine learning to be able to integrate that information and really to weight, some information over another. As you saw in the SHAP analysis, we're weighting some kinds of information more than other because they have more predictive value. So I think those approaches, and I'm sure they probably are already being applied to the animal model world. But what we've done in the using ethovision, and now we're using computer vision, but ethovision is another technology that allows you to track movement. It uses color to differentiate two people in this case. So the parent and child come into the lab, one wears a purple shirt, we give them, and the other wears a red shirt. And then we have a camera up above that tracks the movement of the child and the parent. And we published a paper last year where we were able to show that we could measure the degree of synchrony between the two, and also whether if the parent did something, did the child follow, or vice versa. And these digital signatures of parent-child interaction were correlated with standardized and objective measures of social abilities and so forth. So we do think that this is a promising area to also use these methods for tracking movement, both in the context of animal models and in humans.
Thank you very much. Yeah, I learned a lot from your lecture and the Q&A session. So thank you very much. And I think all participants enjoyed her talk very much. So lastly, I'd like to introduce CINP and also CINP World Congresses. So I'll share my screen. So can you see? So this is the introduction of CINP. So in the International College of Neuropsychopharmacology, CINP, is a truly worldwide organization established 67 years ago in Zurich, Switzerland, and can count on a widespread support from all over the world by its active members, holding regular meetings in form of training, educational programs, international meetings, and world congresses. CINP reaches interested researchers all over the world. Clinicians hear about the latest research advances and new treatment. First, researchers hear about new clinical needs and problems. Therefore, CINP is dedicated to promoting research and education on a worldwide basis. And in 1950s, chlorpromazine and imipramines were discovered. So innovation in psychiatry therapeutics started in 1950s. So at that time, CINP was established. So this shows the former presidents of CINP. And as you know, the 11th president of CINP was Professor Arvid Carlson, the Nobel Prize laureate. And the 12th president was Dr. Paul Janssen, who established Janssen Pharma. So CINP led neuropsychopharmacology in academia and also industry. So this shows the current CINP board members. So the chair of this webinar is president of CINP, Professor Joseph Zohar. And I'm the president-elect of CINP, and I'll serve as president after the Tokyo Congress this May. And there are many researchers from all over the world. And I'd like to introduce Tokyo Congress, CINP 2024 or Tokyo Congress. This is the 35th World Congress. It will be held from May 23rd to 26th this year, and the venue is Tokyo International Forum. The main theme is new wave of neuropsychopharmacology toward well-being. 30 seconds. So this shows the programs of the Tokyo Congress. So there are 7 plenary lectures, 25 symposia, 11 spotlight sessions, 2 meet experts sessions, more than 700 oral poster presentations, more than 30 co-sponsored sessions, more than 15 exhibitions, and 1 public symposium. And there are social events, opening reception, dinner cruise, farewell party, and early career get-together. And regular online registration deadline is May 10th. And we can accept the registration at the venue. And this shows the tentative timetable. So from morning on Thursday, May 23rd, to the evening on Sunday, May 26th. And this shows the plenary lecturers. So Professor Lee and Professor Joshua Gordon and Dr. Haruo Naito and Professor Bryce Hacker and Professor Belinda Lennox and Professor George Koo. And one open slot is for the new CINP president-elect. So we are now under the election of president-elect. And this shows the spotlight sessions, pipeline and newly launched medications, 1 and 2, and global networking communities, worldwide organizations such as CNP, WPA, and WFSBP. And neuroscience-based nomenclature, and Asian College of Neuropsychopharmacology sessions, and Taiwanese Society of Biological Psychiatry, and Philippine Association of Psychiatry, and euthanasia and psychedelics. And we have many kinds of awards, and these shows the awardees. So we selected 31 students for Student Encouragement Award. And last year we held World Congress in Montreal, and this year in Tokyo, and next year in Melbourne, and in 2026 in Glasgow. So Tokyo, Melbourne, and Glasgow. So I hope all of you can participate in all of these CNP World Congresses. Yeah, so thank you very much, Professor Dawson, for your wonderful lecture, and thank you very much for kind attention for the audience. So I think you enjoyed Professor Dawson's wonderful lecture. So thank you very much for your...
My pleasure.
Yeah, thank you very much. So Yossi, could you close the session?
Yeah, okay. So it's really my pleasure to close the session. As I mentioned, it's part of a series of webinars that CINP is doing as part of the mission of CINP to increase knowledge and awareness and improve the treatment of disorder of the brain. Thank you very much for joining. And for those of you who are good night or good afternoon or good morning. Thank you very much.
Thank you very much.